So my name is Catherine. I'm a nurse that works in the ILD clinic here at the Edmonton Clinic. And I'm not a research nurse. So this has been a great experience for me for like really diving into what some of the clinical trials and things are that are happening. Um, I work with Dr. Mina Kaluri and Dr. Sani Vahidi and Dr. Giovanni Ferrara. And Dr. Kaluri especially really focuses on symptom management and definitely want to use the most up-to-date therapies, but sometimes those therapies that are being developed, we don't, because they're not like immediately available to us, we don't spend a lot of time looking into those. But having said that, there is some interesting things to share. Um, First off the bat, I'll say if I'm certainly not feeling like I'll be able to answer all the questions, but any questions that you have, I'm going to jot them down and get back to you without through Jamie. I'll just find out the answer and get back to you.
Yeah, that
Uh
sounds good.
yeah. And yeah, so we'll just do a quick review of this or the few of the objectives. Just a bit of a review of ILD, inflammation and fibrosis. Review of current approved therapies. This will be kind of fast, and then kind of what clinical trials are, the phases, and how to search for clinical trials, and then current trials that are recruiting and trials that are going to be recruiting, and then closed trials that have some hopeful results. So just as a quick review, oh, and also again, any information pertaining to your health should be discussed with your physician. And this is all just general information, not to be taken as advice for you specifically. So if we think of all lung diseases, like COPD, asthma, cystic fibrosis, emphysema, those are not interstitial lung diseases. Interstitial lung diseases are diseases that affect the tissue of the lungs and not the airways. Pulmonary fibrosis is a is a huge part of interstitial lung diseases, but not all interstitial lung diseases are pulmonary fibrosis. But all pulmonary fibrosis is interstitial lung disease. And then within pulmonary fibrosis, we have idiopathic pulmonary fibrosis, which is the most aggressive. And as a result of that, that's where most of the studies usually focus. And then they expand out from there. At any point, if anybody has any questions or comments, be super welcome to let you interject. So what is ILD? It's it's a group of diseases with chronic inflammation of the lungs that cause progressive scarring or fibrosis of the lungs. So this is just a little picture on the left of the lungs with a trachea. Um, so these would be called the airways, and the, the the oxygen gets breathed in through these airways and goes out to these tissues. And if we go over to the right-hand side, the where the oxygen gets passed into the bloodstream is through the alveolus. And so that's why when there is scarring, it happens here. That's problematic when the scarring is in the alveolus and these very, very tiny air sacs, which are microscopic. Um, but with their scarring here, it's difficult for the oxygen to pass into the bloodstream and then carry the oxygen to our bodies. So the damage when they're scarring like that, um, it damages the ability of the lungs to absorb oxygen from the air, and this leads to those symptoms of shortness of breath, coughing, and fatigue. So there's a little schematic here of what kind of the types of things that happen. I just got to move this over here. Uh, when there's injury to the lungs by breathing in something that might cause some inflammation, then there's injury to the cells in the lining of the lungs. So this is going again all the way down to the alveoli. And then at that time, there's secretion of inflammatory agents first and foremost. And then they also release these platelets. And then when the platelets are released, it opens up the vessel walls, and that um, lets more inflammatory cells escape. And the white blood cells release pro-fibrotic cytokines. So these are these inflammatory mediators, and they release these cytokines. Inflammation causes this cell migration, and these agents here, this is all where a lot of the research goes in how do we stop in this whole cascade, all the different places and ways that this process can be halted or stopped. So then we get the recruitment of fibrotic cells, myofibroblasts. Fibroblasts go to myofibroblasts, which leads to this extracellular matrix deposition, and that's what forms the scar in the lungs. So if you can slow down the process here, or from here, or from here, then it can reduce the possibility of scarring. But then with this, when this scarring happens, especially in idiopathic pulmonary fibrosis, this is a response to injury that doesn't stop. It's supposed to stop, like in a wound when somebody gets a cut on their arm and there's a wound, normally the scar closes up and it stops. But with this type of process, this wound healing just continues. And so the scarring continues to form. And that's why it's a problem, particularly in IPF. So some of the current things that are used already for some of the current medications used for treatment for pulmonary fibrosis and lung diseases is antifibrotics, obviously, for infections, immunosuppressants. These are effective for helping reduce the inflammation for patients that have lung disease that's caused by inflammation more so than the scarring. And then antifibrotics, I think we're all familiar with the role of antifibrotics with Ofev and pirfenidone. Those are the two approved antifibrotic medications. We also have opioids. They're very useful for management of shortness of breath and cough, which we're going to see a clinical trial that actually shows this. And then oxygen is also considered a medication, and it's prescribed to prevent damaging effects and the discomfort of hypoxemia. Just that one quick question. So, does anybody here um, been investigating or learning about any new trials before I move forward? I just want to know what's your interest or awareness.
So Catherine, we did have a session on an app called Hail Mary last fall
An
on
app?
how, yeah, so it's an app and a website called Hail Mary, and it will help people find clinical trials that they may be candidates for, and then it'll connect them with researchers once their doctor gives them the okay and they're pre-screened to ensure their doctor's okay with it. If anyone else wants to jump in, unmute yourself and let us know.
No. Okay, no worries. So, so anyway, so for clinical trials, there's phases of clinical trials. And but before they even start the phase 1, there's the whole process of developing the molecule or the intervention. So the first phase 1 in a clinical trial, like it says there, it's when there's a new drug or treatment, it's given to a small group of people. Often they're healthy volunteers who don't have the intended disease, and that's just to evaluate its safety and identify the side effects. Phase 2 clinical trials are usually part A and part B. This is with a larger group of people with the disease, and they'll receive the treatment just to see if the treatment has the intended effect. Um, that would be like primary endpoints, secondary endpoints is what they refer to them as. And then phase 3 clinical trials are a much larger group of patients that have the intended disease or the disease that the intervention is for. and they'll receive the treatment to confirm its effectiveness and safety. But these patients, they all have to fit inclusion criteria and not have the exclusion criteria, which is sometimes can be quite involved. And then phase 4 clinical trials are sometimes conducted after the treatment's already been approved for use to get more information on its longer effects on much larger groups of people with the disease. So you guys mentioned you mentioned a place to go to find clinical trials. I'd also share two other spots. One is called clinicaltrials.gov, and that's a pretty involved website that's pretty um, quite global in nature, and it identifies all the clinical trials that are existing, and it tells if they're recruiting or not recruiting, and you can even see trials that have been completed or stopped, and they're no longer uh, the molecule or the intervention is no longer being used in any way. So those clinical trials, that there's a lot, there's tons. Let's just say there's tons, and there's a lot of interest, many clinical trials, and a lot of development of treatments to try to help with idiopathic pulmonary fibrosis and other types of pulmonary fibrosis. So many times, though, they don't go past phase 1 clinical trials. Sometimes they are very, there's one that it was called Starscape. Was anybody here in the Starscape clinical trial? Here? No, you weren't in it, Tapan?
No, I was initially contacted, and then for whatever reason, I was told that the opportunity window was closed, so I
Oh,
did not.
okay. Okay, yeah, there's like a recruiting time and then but anyways, phase 2 seemed quite promising, so they moved into phase 3 clinical trials, and they did a whole lot of work and got some patients recruited, not just here, but in multiple sites, but they had to stop it because it wasn't showing the primary endpoint that it was supposed to. So they don't, once that happens, they just stop the whole trial. So there is a really interesting video on clinical trials if you're interested. I have the link here. It's just on the Canadian Pulmonary Fibrosis Foundation website. Uh, but I just wanted to add at the bottom here that sometimes it can take up to 10 years from discovery of a molecule to approval for use based on the safety and effect. So it's not something that happens quickly. Mind you, with the development that they've done, not only with because of the mRNA vaccines and all that research that's been very progressive. Hi, yep, Tapan, you want to say
Yeah, go
something?
ahead,
So,
Tiffin.
so just wanted to understand a bit better when you said of the particular one trial where it was ended or abandoned at stage 3. Does that mean that that particular drug development ended? Like I understand that to develop a new drug is very expensive, like billions of dollars and so on, and only 1 in 10 or something like that succeeds and the others are abandoned. Is that the case with the one that you mentioned, Catherine?
Yeah, my understanding is that the data that they found that they used to actually proceed with the phase 3 clinical trials, um,
Mm-hmm.
later in retrospect, there was like some outliers. They call them outliers where people had like extremely good responses and
Right.
kind of skewed the results. That's my understanding. But yeah, I don't
Mhm.
think that it's not existing anymore.
Okay, and after
Okay.
this session, I'll post the links to the clinical trial sites like clinicaltrials.gov as well as the video on clinical trials.
Oh yeah, and also besides clinicaltrials.gov, there's another website. It's called Be the Cure, and that's within Canada, and you just look in under the province of Alberta, obviously, and that's a really nice website too. It's not quite as involved as clinicaltrials.gov, but it's up to date. It's
Hmm.
definitely up to date. Yeah.
Okay, well, I like that there's a Canadian option.
Yeah, for sure. Okay, so then I'm just gonna jump into one that's actually recruiting right now. It's in out of Sherwood Park. This this is called Bristol Myers Squibb. That's just the company, and that's the agent 986278. This is um this is a clinical trial that's for patients that are 40 years or older. They have PF, IPF, or progressive fibrosis, and it's possible to be on or not be on an antifibrotic. But if they're on an antifibrotic, they have to have been on a stable dose for 90 days. And then if you're of childbearing years, both male or female, not that males can, but if males can be married or be sexually active with a female that is of childbearing age, they must use special precautions. But this is a pill and it's twice a day for 52 weeks. And it's taking a pill twice a day. It reduces the rate of the decline of the forced vital capacity after 26 weeks in the phase 2 clinical trial. So that's why they're moving to phase 3 clinical trials. Um, the primary outcome is a slower decline in the forced vital capacity, so your lung function, compared to the placebo. And I did contact the site in Sherwood Park to find out if they are recruiting. And the person's name is Kylie Hayday, and she said we can call her or email this address. So what is this drug? It's called LPA1 blocker or antagonist. So I found this sort of another schematic also of the fibrotic process. And I like it because it shows where some of these agents that we're going to be talking about actually work. So OFEV or nintedanib, it works. So it works here to block this process from moving on to myofibroblasts. So this medication is just a pill. It's a LPA1 antagonist. So this one also works in a similar fashion with nintedanib, only in a different pathway. And it works towards slowing down or stopping this progression to the myofibroblast differentiation, and which then again leads to this. This is ECM at the bottom here. That's the extracellular matrix that we want to try to block from forming or getting worse. So that's OFEV. And this is this other one, Bristol Myers. We don't know a whole lot more about it. We don't even know what the name of the trial is going to be. She was a little cryptic when she sent me the email that saying where we could message her or how we could. She can't really tell much more information, but you can just get in contact with her if you're interested, and just go from there. And then she'll move forward with figuring out what is the if you fit criteria.
Catherine, just before we
Yeah.
move on to the next one, can you explain a bit more about what FVC is?
Oh, sure. We'll be coming up to that soon.
Oh, perfect.
Is everybody wanting to know that, or do you guys know what force vital capacity is on the pulmonary function test? We'll come to it in just a minute.
We'd like to know, yeah.
Okay. Yeah. Okay, so force vital capacity is when you're doing your breathing test and the full I think everybody here has done a pulmonary function test when you are told to blow, 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 blow. The forced vital capacity is that full amount that you blow. And when they say blow, 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 they're making you push out as much as you possibly can. That volume of air that you're blowing out, they measure that as the forced vital capacity. And so for patients with pulmonary fibrosis, there's a lessening or the amount that they can blow out is sometimes less. And as disease progresses, also just with aging, that amount lessens with age and with time. So what they're looking at in clinical trials very often, the endpoint is what's the change in the forced vital capacity. So for example, with OFEV, why the reason it was it was touted as such a positive thing also with pirfenidone is that the forced vital capacity after patients had been on it, the rate of decline of the forced vital capacity was less than the rate of decline for patients that were not on those agents. So we expect a certain amount of decline, and it was less on those medications. So that's why now moving forward, they're always looking at forced vital capacity improvement or decline. Not so much that it's always you're going to be able to stop it from declining, but you want to slow it down. So that's why the forced vital capacity is one of these really important measurements. But I think all of you who have had lung function tests know that there's a tremendous amount of variability when you're doing lung function tests. You may not feel as good one day or another day, or you may have be quite exhausted, or who there's all kinds of things because we're people and we're not the same day to day. So it's not quite as it's statistically significant for sure, but there's also some variability. But it's the best that we have, except for you're going to see one thing that I'm going to be able to share that's kind of uh, on on the up and up about that. So we're not only looking at forced vital capacity, we're looking at other things. So move moving on to this next one is called Teton, IPF and PFF. And this is a phase 3 trial investigating the safety and benefit of treprostinil for patients with IPF and also for progressive fibrosis, ILD. So there's a little bit of a history to this drug. It's not a new agent. It's been around for a long time. It was originally used for patients with pulmonary hypertension. Actually, it should say PAH, so primary arterial or pulmonary arterial hypertension. So it's been around for a long time. That's over 22 years. The way it's used is to open up the arteries that are going from the heart to the lungs. It's an infusion administered under the skin, and it's kind of a difficult thing to live with. It has to be running all the time. This clinical, this the agent or the medication that they calling treprostinil in this form is called Tyvaso, and it's an inhaled form, and it was approved for use in pulmonary hypertension, patients that had pulmonary hypertension secondary to lung disease. So that was approved in 2009 in the United States, but not in Canada. So, but when they did the clinical trials and they figured out the benefit of using this medication for patients with pulmonary hypertension secondary to lung disease, which by the way is called group 3 pulmonary hypertension. When they did all the research and all the clinical trials with that, what they found is that the patients that had pulmonary hypertension secondary to having interstitial lung disease, what they found is that fibrosis, the forced vital capacity, actually improved when they used this medication for inhaling it. So that's why now they're rolling that into clinical trials for patients that don't have pulmonary hypertension, but they just have fibrosis. Does that make sense? Yeah, no.
Yes, yes.
Catherine,
Okay.
just one quick question. Do
Yeah.
you from like Dr. Kaluri has, so many patients under a treatment. Has she given this as a treatment for any of her patients?
That's an impossibility. It's not a possibility right now. So this is the effort to get that to happen if it's going to be effective though.
Oh, okay. So is that to be prescribed by physicians yet? It's still clinical trial, right? Is that what you're saying?
It's still a clinical trial for
Okay.
for
All right.
for that indication.
Okay.
So it's called Teton IPF, and it's to evaluate the use of this treprostinil in patients with fibrosis. And I think I explained it's,
Yeah.
how we
Okay.
got there, right? Um,
Okay. I
so
understand.
now it's moved into this phase 3 double-blind placebo-controlled trial. But this is how to prostacyclin, and it's still very, very currently used in Canada for many patients that have pulmonary arterial hypertension. It's a continual infusion that goes under the skin and it goes directly into their bloodstream. And it helps those arteries stay open so that they don't have as much high pressure in their pulmonary arteries, leading to breathlessness. So that's for pulmonary hypertension. We would never be getting this for patients with IPF. However, the other form is an inhaled form called Tivasol, and it's used. This is a little device that's used to inhale the medication, and it's to be done 4 times a day. Um, and so the way it works, it relaxes. The way it works in pulmonary fibrosis patients, it relaxes the blood vessels in the lungs. And when they're relaxed, it's easier for blood to flow through the lungs, causing them less strain and making it easier to get oxygen and to work better. Inhaling allows delivery directly to the lungs, and it stops it from having to go through the gut and be metabolized. It measures the lung function until clinical worsening, and overall it measures lung function. I think my little thing here is blocking some of my words. Until clinical worsening and overall survival. So the design, it's a 52-week study of inhaling this medication 4 times a day through a nebulizer. It's restrictive in that the only site in Canada right now is at St. Paul's Hospital in Vancouver. But I did contact them and I said, what would it entail for patients from Alberta? She said, absolutely, patients from Alberta could enroll, but what it entails is traveling out of province to Vancouver, 8 visits in 1 year. The company is a very rich, rich company, United Therapeutics, you might have heard of it, and they would be able to reimburse for flights and hotels. So anybody interested in finding out more, they can contact this person, Mindy Mock. She's the main coordinator for the study, and she's out of the Providence Health in BC, and that's her number and her extension. Again, these kinds of things are not for everybody, but it's actually one person said, well, hey, maybe we could request to be a site for this trial. That's always a possibility too. So things are always moving forward, and the more we talk and the more we kind of try to find out how we can get involved, who knows, maybe we could become a site. But this again, this is going off of successful phase 2 clinical trials, but we don't know anything about the phase 3 clinical trials right now. They're still happening. And I think the idea is that this would end sometime in 2025, the data collection. So then this is something also, I think Lloyd and Margaret would be aware of this. There's something called the ABILD project where this is an effort of, they call people stakeholders that are, patients and physicians and respiratory therapists and people, allied health members that are involved with patients with ILD, just to try to improve the pathway for diagnosis for patients with ILD, to improve the time to diagnosis, to improve support in the whole province, um, especially rural access, because right now rural access is difficult. And interestingly enough, what we had a meeting just last night, I think, that talked about this, some of the findings. And what was discovered is that there's more patients in rural Alberta than the urban centers that have idiopathic pulmonary fibrosis or interstitial lung disease in general. We have a lot of work to do to reach more of those areas with better services and better education and better access to oxygen therapy. So patients participated in a focus group, and I think some of you here did participate in that survey. And then there's meetings with ILD specialists and other stakeholders and surveys. And this is just an ongoing thing, this AB-ILD project. And there's several aims identified, but the one that I wanted to share is aim number 3, and that's called the feasibility trial. The objective of this trial is to see, we're always trying to figure out ways to get oxygen more accessible to people and more more data. Every time people talk about the benefits of oxygen, then you're always left with, well, we need more clinical trials to prove it. Well, it's a very difficult thing to prove um, for multiple reasons. And that is the idea of oxygen in interstitial lung disease because of lots of reasons. But anyway, so the objective of this is for the delivery of exertional oxygen and support tools in ILD patients with low oxygen with exertion only. So for patients that are not on oxygen right now, it's a trial to help them. There would be like 3 different arms, people with not on oxygen, people on oxygen only for exertion, and people on oxygen with support. It's just a 2-month program with crossing over, and the data from that hopefully will show that the best result is oxygen with support. So it's happening, not, we don't know when, but I think Lloyd and Margaret, believe he said probably in a month or 2, but I don't know if that's ambitious or not. Yeah, Margaret, you want to unmute?
I just have a question. What, maybe I wasn't listening, but O2 with support, what does that mean?
I believe that means just with education and titration.
Okay,
Yeah,
so
just
that's different than just like, that could be somebody on oxygen full time, like at rest and at exertion?
I I'm not 100% sure.
Okay,
I'm not sure. That's a great question. I will find out.
thank you.
Yeah. So the primary outcome being assess the feasibility of oxygen support program 8 weeks. And other outcomes, I didn't finish that. So then here's another one, and this is kind of more applicable to everybody, I think. So this is another one that's not recruiting anymore. It's complete. So if you remember, our objectives were looking at clinical trials that are recruiting right now. So those are the 3 that we saw. And now I want to move on to some that we've actually have results from that are completed. This one is called Pacify, and it was a study done about morphine for cough. So this is like the first trial to report the benefit of morphine, which is an opioid for cough in IPF. What they did is they used this little device, it's called a VitaloJack, and they measured how they measured cough intensity and frequency. And they did it with using morphine to try to help that cough to see if there was a difference. It was a prospective, multi-center, randomized. All these are clinical trial jargon, but it just means that they used placebo. So it was controlled in that patients were given morphine and other patients were given not morphine, but they didn't know who that was, who would be getting morphine and who wouldn't. It was to examine the use of low dose, so 5 milligrams of morphine, which is quite low, and that's an extended release form of this medication for people that really have very problematic coughs. And it was specifically only for IPF patients. So the population was patients with mild to moderate IPF, and they had to be diagnosed within 5 years with cough severity of more than 30 MMs on VSA. I apologize, I don't know what MM is, but what they did, so of course we're looking at the endpoint being, or the goal to see if the cough frequency is less. Basically, the cough frequency was 39% less frequent, and the medication was well tolerated. So of course with morphine, and it's an extended release form of the medication. So it's not a new drug, it's a very old drug. So it's not like the same kind of clinical trials that are looking for safety and efficacy and all that stuff. That's already been done for morphine. It's just seeing, does it have the effect of helping with cough? So in this clinical trial, it showed that yes, it definitely did. It was well tolerated. The side effects from morphine, I think, is primarily like you can get constipated. You can also have just a little bit of drowsiness, but for the most part, it was well tolerated according to this Pacify study is what it was called. So there's a interesting, again, a webinar on from the European PFF Summit, which was the most recent one. And with their summit, then they add these webinars, and one of the webinars is about cough in IPF. And he talks about this trial, and that's the link at the bottom there to that webinar if you're interested.
Okay.
I want, Mhm.
Sorry to interrupt, Catherine, but I can maybe shed a little bit light on the MM. So
Oh,
the
okay.
VAS is a visual analog scale. So
Oh,
it'll
okay.
range the assessment for cough severity from a 0 to 100 mm scale. So no cough is 0. The worst cough possible is 100 mm. We're probably more familiar with the 1 to 5 scale. But if it's more than 30, it's considered a severe cough.
Okay, thank you so much, Jamie.
Yeah, no problem. Also, I'll post that link as well to that webinar, if anyone is interested after the session.
Okay, so but one thing I wanted to say about cough in particular. So this is like updates in in pulmonary fibrosis and treatments and things. One thing we were really hoping that gets better understood is how breathlessness worsens cough as well. Um, this is a slide from uh, his talk about cough. And he was talking about what drives cough hypersensitivity in ILD. So we all know that there's sometimes cough can be very, very disturbing and very, very hard. And of course, now we see morphine is one of the tools that can be used, like extended release. So it's in your body for a long, long time, a very low dose. But I just wanted to point out one thing. When he was talking, he talked about how the brain's involved in the hypersensitivity and inflammation from the ILD, and the sputum production can also stimulate cough. And reflux, or that's gastric esophageal reflux disease, that can also be a contributor to cough. But then he jumped over here to the nerves and how the nerves are implicated as well in causing cough and everything. And he didn't say anything about this. And I was a little puzzled. I don't know why, but I think it's not something to overlook. It's very important to recognize that breathlessness or having low oxygen levels can make your cough worse. And so I just wanted to highlight one in particular lady that this was really evident in her. So she's a patient of ours. She's been on oxygen probably for more than 7 years. High flow oxygen, mind you, 7 years. But she manages her symptoms very, very well with using opioids for her cough, high flow oxygen, and she does not experience a really bad cough. And patients like that, we learn so much from. And I just really just wanted to put a plug in there because many times when you're learning about clinical trials and they're looking at all these endpoints and things, even using pills to lessen cough, no pill is going to help your oxygen levels go higher. And if your oxygen levels are low, that can sometimes stimulate a cough in some people. Not everybody, but some people. Okay, so that's my little spiel about oxygen. So Fibroneer, this is now we're going to move on to trials that have been completed and we're kind of waiting for the results. This one, I'm just going to look at the time. Do you guys know what the score is?
It's
Any updates?
4-2 Oilers.
Get out!
Mm-hmm.
Oh, wow. That's great. Okay. Anyway, so Fibroneer, this is a pill, and it's a clinical trial that we did run out of this site. And not me personally, because I'm not involved in these trials, but just making sure there's a room for them to be to meet in. But anyways, this was a phase 3 clinical trial, and it was to evaluate the the efficacy, the safety of this agent. It's called nerandomilast. Neran no, neran nerandomilast. And the company is BI, so Boehringer Ingelheim, and that's the same company that created nintedanib or OFEV. This is the number, and it will use 9 milligrams or 18 milligrams of the pill plus placebo, and the patients got this twice daily over at least 52 weeks. And it was an investigational therapy for people with idiopathic pulmonary fibrosis and progressive pulmonary fibrosis. So the place that this one works is over here. It's a PDE4B inhibitor. And so just in general, it stops tumor growth factor beta 1 from progressing on to this pathway, and then this pathway forming these, and then forming the extracellular matrix. Again, it's all very complex, but I think it's interesting to see it works in a different pathway than OFEV. And if you see down here, this is where pirfenidone, so it's more similar to the part of the pathway where pirfenidone is affecting. And I don't know. So this is treprostinil. This was the Tivaso. I forgot to show you that this is where that medication is effective. And just backing up a bit for that inhaled one, the reason that it would be needed to be inhaled instead of just taken as a pill is because it would, if it's metabolized, then it would break down. It's got a very short half-life, so you need it in your body it needs to be sustained in order to keep the arteries open. So anyways, this is where Fibroneer works. In terms of uh, the results, we do not have the full results yet. The way that they are checking these, the way that they're, this is just, I've just plunked this in to show this is how we measure the forced vital capacity. It's with these pulmonary function tests, like we mentioned. And so this is why they're excited about this Fibroneer or this agent is because the primary endpoint was met, the absolute change from the baseline in this FVC, so the forced vital capacity at week 52. So if we look here, this is just a 12-week snapshot, but the red line is the patients that are their results on their breathing tests. These are the patients that were on the agent, so that are on this medication, this pill. And at the end of the 12 weeks, the change in their forced vital capacity was actually even slightly higher than it was before, which is never seen. Never, never. And then, except for, of course, at the the inhaled study where they showed the forced vital capacity was improved. So, but with OFEV and nintedanib, we don't, and the pirfenidone, we don't see an improvement in FVC. We see a slowing down of the decline. So these, and the blue line is the patients that were not on that medication, a placebo, and we see that their forced vital capacity did decline as per expected with idiopathic pulmonary fibrosis. So this was a positive result. And patients that were in this clinical trial, I believe it's gone to open label access. So the patients that were on it for the clinical trial, now they can be on it. And so even if they were on placebo, then they are given the actual medication. So that's kind of how those clinical trials work, if it's a positive result. But the complete update and the information about it and where to go from here That's coming in the fall. Does anybody have any questions about that?
So, Catherine, can I ask about that? So in this case, this medication is between the completion of the clinical trial, but not at a marketing or approval stage yet, sort of somewhere in between, correct?
That's right. That's right. Because if you remember with OFEV, like there's a bit of a process getting a medication actually approved.
Right.
Um, and once it's approved, then getting it covered by the government is another step. So, but we don't know how expensive this would be. We don't know very much yet. We know the number and we know the name and we know that it was positive.
Right.
Yeah.
Right. Okay, thank you.
So then there's another one here. This is called the Whistle PF trial. This is a trial that's not started yet, but we anticipate being a site for this clinical trial. And it's the company is called Endeavor, and it's a medication, it's a pill, and it's an oral molecule inhibitor of the hedgehog pathway. Don't ask me to explain a hedgehog pathway, but it's it's something that happens in fibrosis, not only in lung fibrosis, but in other types of fibrosis. So this is a medication that actually has been shown in phase 2 clinical trials to actually improve the forced vital capacity as well. But not only that, it's also improved the percentage of fibrosis on CT scans. And this hasn't really been done before. So there is a plan for a 2B, phase 2B trial, which we're, we've been claiming that we will do it here. And then from then you would need to go on to a phase 3 clinical trial. But this was highlighted at the American Thoracic Society conference in San Diego in just last month, actually. So this is just a slide. And so we talked, the forced vital capacity, I think, is the next slide, but this is one that shows actual fibrosis on CT. So, uh, and so if we look on these graphs, like I'm not a big fan of graphs, but I think it's pretty clear. So this first one, it's showing just all interstitial lung disease, not we know interstitial lung disease, there's the fibrosis and there's inflammation. So this is all fibrosis and inflammation. And this is over time with this medication, this is the lesser, so going below the zero level is an improvement or a lessening of fibrosis and increasing of fibrosis. So this is patients on this agent, and this is patients not on the agent. So there was an improvement in fibrosis, lessening of fibrosis or ILD, sorry, in these patients that were on the medication. Then they looked at just fibrosis. So how much of just fibrosis was less? And again, patients taking this medication versus the patients on placebo, their level of fibrosis improved, and the patients on the placebo had more fibrosis over time. And then this is about inflammation. So ground glass, you may hear ground glass opacities, GGO. That's a way of looking on a CT scan and seeing inflammation, not fibrosis, but inflammation. And if there's ground glass on a CT scan, that's hinting at a potential for some reversibility because we can treat inflammation with some of these agents like these anti-inflammatory like prednisone, mycophenolate, Imuran, some of those medications that help with inflammation. So anyways, that's kind of a new thing, and that's quite exciting. And we're also excited to be a site when this gets off the ground. Don't know when that'll be though, but that's called Whistle PF trial. And this is like this is your hedgehog. So you can send this out and study this, but this is how it works. It blocks a hedgehog pathway and causing myofibroblasts to undergo apoptosis, so die, and eliminating the driver of the IPF pathology. So that's the thing that causes the wound healing to continue when it should stop. So it kind of blocks that, enabling resolution of the wound remodeling disorder, meaning it makes things better. It lessens the fibrosis.
Mm-hmm.
That's how it works. Yeah.
Yeah, so I can actually shed a little bit of light on the hedgehog pathway.
Oh, can
It's
you? I don't know. I've never heard of it
luckily
before.
I studied a little bit of this in school. So there's
Cool.
a gene called the sonic hedgehog gene. It provides instructions for making a protein that functions as a signal for proper cell development. In IPF, when this pathway gets activated, it's a big cause of the damage that could eventually lead to IPF as well as worsening of the condition. So by inhibiting this pathway, they reduce the amount of damage over time.
Thanks so much.
Yeah, no worries.
So then here in looking at the change in forced vital capacity to measure the benefit, if we were to go back, this one on the left, well, it's my left, maybe it's your right. This is what we're very familiar with this with OFEV or nintedanib, that with the decline of the forced vital capacity over 52 weeks, this is the patients that were on the agent OFEV. Their decline in forced vital capacity was this much, and the patients that were on placebo, their decline was much more. So that's then we can compare and go back to this one. That's that agent that I was telling you about. That's called oh, it's the other BI medication. I'm drawing a blank.
Fibroneer.
Fibroneer. Thank you, Japan.
Mhm.
So this is how Fibroneer is actually quite stabilizing. You see, it's actually good. It's better after a couple of weeks and up and down, but then but the thing about forced vital capacity, again, that's being measured, and it's a dynamic thing where it depends on a few factors, where CT scan is actually not CT scan isn't something that you is dependent on how you're feeling. So it's a little bit more positive or trustworthy. So those are the things that we have that are medications. Dr. Clary thought it would be good just to touch on a little bit of things that talking about the future. You probably many of you already are very, very tech savvy and learning about AI and things like that. So I think bottom line is it just we're going to be able to do more remote helping patients, uh, more accurate where reading of data, constant data. So instead of just a one shot looking at your pulse oximeter, you'll be able to see what it is over time with all kinds of activities and just lots of data collection, lots of tuning in to patients and their needs. But really, this is way out of my way out of my comfort zone to talk about. One thing I would say though is there is one of our patients that he's a real AI person, and he was showing me the other day, he said to me that Chat GPT or AI is going to be able to, pretty soon you'll have your own person that you can actually just talk to, like a person it'll be a computer and they'll answer all your questions for you. He said, just wait, that's gonna be coming. And so just out of curiosity from him, I did download ChatGPT a couple weeks ago with Dr. Clury when we were looking at something. And then I turned it on today, and exactly what he said is happening. Exactly what he said is happening. You can just talk to it and it'll give you any information. So, precaution, I think it's important to be really, really aware of those. Oh, beware of those things. But, anyways, anybody else want to talk about wearable technologies or AI? Because I'm finished.
So, Catherine, just from my understanding, they're looking at doing machine learning and AI for um is this sort of like a just an adjunct therapy in a way? So smartwatches, for example, they'll track your heart rate, how many steps you do, things like that. It's mostly just a health tool for people. Like, is that my understanding? And then for biomedical sensors, it's just an extra way to track data and track your baseline and just the changes in your health. So
Yeah,
your family physician or your caregiver can get a better sense of how to
yeah.
plan your
So
care.
yeah,
Okay.
so then and that you wouldn't actually have to come in and be seen all the time, that some of this could be um communicated to your healthcare provider remotely without having to travel long distances, particularly for patients that live far away from centers. But lots of unending uses. And
Yeah.
it's just basically medicine is going to be changing quite a bit
It is really
with,
interesting. I would love to like learn more about ingestibles and smart implants. I think I've heard of ones for mostly gut disorders, but I haven't really heard
yes,
anything in the pulmonary space yet.
yeah, yeah. Anybody else have anything to share about that stuff?
I just have one question about the picture there. It
Yeah.
looks like on the right they're showing like a bunch of different monitors. Like are there currently options to monitor oxygen continuously?
Yes.
You can get
Y
now?
Yeah, so there is like this is when this was pulled, I believe this is actually of pulse oximetry. So um but of course the standard one is like the pulse oximetry that we put on the finger, but lots of watches can be very accurate now in continually monitoring oxygen saturation. And all these other devices that I really don't know very much about. But yeah, that's the idea.
Okay. Because it's something you might be interested in getting. Like, if we wanted to get more information on what's a good product to buy for continuous oxygen monitoring, like, you know how we could
I'll
get more
I'll
info?
I'll I'll totally investigate that and get back to you guys about that for sure.
Thanks, Catherine.
We
Yeah.
would be very interested in that too. Yeah.
Yeah, yeah. And yeah, I know that and there's a lot of value to that, especially if you were to sh well, it's 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 obvious the value that that would be for patients with exertional hypoxemia, especially, you know. So, but
All
Mhm.
right,
I'll
thank you.
definitely get back to that. Get
Thank
back
you.
with that. Yeah.
You have to be careful, honey.
Yeah, so that's oh, I think there's one more slide. Oh yeah, so these are the conclusions. The current trials that are recruiting this Bristol Myers Squigs 986278 that doesn't have a name yet, that's being recruiting out in Sherwood Park. That's one that's going to be it that is recruiting. Teton, she does say you can connect with her and she can start the process of talking about inclusion criteria, seeing if you fit criteria. And then trials that are going to be recruiting is that ABILD one about oxygen and the Whistle PF trial. And then the closed trials with hopeful results will pacify. We already know the results are good, but Fibroneer is the one with hopeful results. So, and that's all I've got, but it's a real delight to see you guys. So I'll just stop sharing my screen here.
All right, thank you so much, Catherine. So I'm just gonna yield the floor to anyone who has questions.
Oh
Tuppin, you're
boy.
upside down.
Oh, I don't know. Okay, I'm good now, I think.
That's
Yeah.
okay. That's okay. I think when you're walking around with your monitor mirrors and then it flips.
Right. Yeah, no, I'm good now. Good now. I also have to leave. I have a bit of a family thing going on, so I didn't want to miss this presentation. So please excuse me.
Well, thank you so much for joining us. For anyone who's curious, the score is 4-2 right now. Oilers are leading.
Great.
I have a little score tracker on my phone.
So what do you guys think though? Do you think that maybe this is a really negative way to think, but do you think that maybe the Panthers are going to just let us win for the couple just so that there's more games and more money to be made from these
Well,
games?
that is a consideration. That's probably
Maybe,
why
yeah.
they let us win on. They didn't let us win, but 8-1 or 8-2 or whatever it
Eight
was
to
on
one, like
Friday.
that's just
Yeah,
odd.
A little bit
yeah.
surprising,
So
yeah.
yeah, yeah.
What's that?
They're playing their weak guys and saving their good guys for
The final.
the final.
Oh, yeah, maybe.
I bet you
Very
that's true,
cagey.
Dale. Yeah.
Yeah.
Well, we can enjoy it while it lasts.
That's right. That's right.
Okay.
But they
Kat,
That could be a bad move on their part. You never know.
yeah, we
Yeah.
could catch them unaware. I don't think they were expecting to lose quite so badly last time. Um, Catherine, I had a question just about the the process of joining trials in
Mhm.
Alberta. Are the changes to the AHS structure affecting any of the clinical trial retention or even just like engagement? Because I know it was affecting some trials. I don't know if it's affecting PF though.
I think what it might potentially affect is that ABILD one that
Okay.
they said just because of the things being in flux, they're not really sure when they'll be able to start. But as far as I know, we still have the PF lab, we still have the setup for the trials and everything here. And I think well, I should hope that it wouldn't impact it too much. But just yeah, it's there's a big question mark there about a lot of things, I think, with what's happening in AHS.
Okay, that's good to know. I guess then that just means it's well, I guess
How
the
is
best
it
way to
how
view
has
it
it
is
affected other trials that you know
one.
about?
So I have a friend who works in IBD and gut research, and I know half of their trials in Alberta have been postponed right now.
Oh,
And that's about 9 different trials.
wow.
But I'm wondering if maybe it more so affects trials that are about to start versus trials that are already ongoing.
Potentially, yeah.
So I guess that means if anyone here is interested in participating in any of these trials, especially ones that are planned, just maybe confirm their expected timeline. But it looks like based on what Catherine said, most of these aren't affected by that.
Hopefully.
Fingers crossed.
Fingers
Fingers
crossed.
crossed.
Yeah. Yeah.
I have a question on the trials. So, like, say for Fibroneer, which was one that I think you had on the list as it's a trial that's completed with hopeful results. At this point, if you're interested in trying that, is the only option just to wait, or do they have kind of interim options for trying these in between when the trial's completed and when the next steps happen?
I'm pretty sure you have to wait for results, but then from that point, um, I'm not sure. So I definitely will get back to you about that too. Yeah.
Okay.
I'm doubting it, but you never know, right? You never know.
Okay, thanks.
Yeah.
Okay, I think we've got time for one more question. Any takers?
So Colleen, where are you from? Are you from Edmonton?
East of Sherwood Park,
East of Sherwood Park. Okay,
right?
like around our Dawson and stuff?
South of Ardrossan, yeah,
Oh, okay.
south of the Y Road, actually. So,
Okay. Oh
yeah,
yeah. So you
yeah.
would go to Synergy then, would you?
No, to Athabasca Clinic in there.
Oh, Athabasca Clinic. Okay.
Yeah, yeah. I'm not on oxygen yet, and I haven't heard anything from them. But my last lung function test, the um, vital capacity was increased. So They said normally that doesn't happen because I'm just on OFEV, but
Okay. Wow. That's good. That's good.
I apologize for joining late. I thought of it earlier and then I was watching the hockey game. I'm sorry.
It is a-okay. It is
And then I
a-okay.
You're
thought, oh
forgiven.
no, I'm missing it.
You're forgiven.
You understand.
Mhm.
Totally. Yeah. So,
Well, thank you.
yeah.
Even to catch what we have caught has been very good. And I understand it's taped so we can
Yeah.
watch the first part. That's great. Thank you.
Yeah. So I think I speak for everyone. Thank you so much, Catherine, for your time this
Oh,
evening.
privilege. Thank you.
I learned a lot. I found it really interesting. My background is research, so I always find this sort of thing very
Oh,
intriguing, and I love seeing how we're progressing in the research space.
yeah. It is quite amazing. It's quite amazing. Yeah. Well, thank you so much. I really appreciate seeing all of you tonight, and it's just been an honor to spend this last hour or so together.
Thank you, Catherine.
Thank you.
Thank you.
Okay. Thank you all.
All right. Thank you, everyone.
Okay.
Have a
Thank
good night.
you.
Bye-bye.
Bye.
Bye-bye.
Bye.